Hello, I'm back. I know what you're all thinking. Where the hell have you been? Well, that's an interesting story. I'll tell you all next week. But this week, we're going to talk with Nitesh, our GP, about medical matters and why we are sometimes considered complete pains in the arses for asking questions about medications. I don't know about you, but it really annoys me when they ask me why we're asking, considering they're asking us to do a surgical procedure on them. Does it wind you up?
A little bit.
A little bit. I'm ahead of you then, because it winds me up a lot. Go on.
Well,
So-
because what we do, it's not a small procedure, but
You're sure now. You've
Any
seen it
means.
yourself.
Seen it
You've seen lots of
many,
things
many,
in the medical
many
field, and
times.
this is not a small thing.
it is definitely not a small procedure.
In
And-
fact, I remember that wonderful day where I sent you for the first time to the surgical hub and said, go and have a gander of that. And remind me again what you said to me when you came out.
I mean, it was a while ago now. Can't
Yes.
quite remember, but I'm fairly sure it went along the lines of, this is really major, what we're doing.
No, I think you started with holy shit, this is really major. I remember that bit very clearly, actually, because you just went, holy shit, I didn't know that's what you did. Yes, that's what we did. So if we look at it alongside, let's say, other medical operations, would you say it's any less invasive than them?
No, it's very invasive and almost getting kind of more invasive as other operations are trying to be less invasive, but ours is as it needs to be.
And you saw with your own eyes how much disease we actually remove, because that's the big part of the surgery, right?
Mm-hmm.
Exactly how much disease did we remove?
All of it?
Yeah, all of it.
A
if we put it into
ridiculous amount?
context, quite a lot
Yes.
in the beginning of the human digestive tract.
Mm-hmm.
Yes?
Mm-hmm. Yes.
So that's why we ask questions about medication, because we need to know that you're going to be safe during surgery, and that is not negotiable, and it never will be either. So we carefully look at all the drugs,
All the drugs.
the list, the big lists that we keep seeing. It is amazing, isn't it, how long the drug lists are.
Yes. Yeah. And I think over
You're
time.
a GP. Why the hell are you lot giving them all these bloody pills, is the question.
Often it's the way that we're taught. It's what happens. Someone comes to us with a problem, and
Here's the pill for it.
here's the best way we can fix it.
And
Particularly in the time frames we have, with the time pressures and everything we have, we do really need to be able to help, and that's what people want.
Yeah, but as that list gets longer, the drug interactions become more profound,
Of course,
and we have to become even more careful
of course.
in how we do things. So it's a bit like a vision. So we're trying to make this person healthier, but because of the drugs that they're already on, we need to somehow negotiate around it. Like, for example, I just want to pull up the HbA1c thing. I know some people get annoyed. Well, why do I have to bring it down? Because you won't heal properly. And we
that's
can't let you do it if you're not going to heal. Sorry.
no, and that's vital. And I say this to a lot of people when I speak to them on the phone, and they are understandably upset. They've got themselves to a point where they've made contact with us and everything, but this is a life-changing procedure
And highly invasive.
highly invasive.
Yes.
And anyone with poor control of their blood sugars causes massive infections, whether you have an operation or not. And that's something that we need to be very careful of, and we need to try and reduce the risk. It's one of the parts of my job here is to make sure that this is safe. And that is what I
Sorry,
tell
is there
people.
anything more important than safety of the patient?
No,
Right,
no,
okay.
not at all.
Just checking.
And
Yeah.
that for me is my biggest kind of job, what to do. And I look through the medications, the medical history, sometimes multiple times, to make sure that this is as safe as it possibly can be.
I want to talk a lot more about this, but before we do, I've been reading on the group that there's a lot of people who'd like to come to All Day House. And what is the big deal about All Day House? All Day House is a realization of a 27-year dream of mine about what, in my view, a surgical unit to do this kind of work should look like. You've been there, right?
Mm.
Are we day case standard?
I mean, the place is incredible.
Medically,
Medically,
do I tick the boxes?
all of them.
All of them.
All of
Right, okay, that's why. So when people ask me, well, why can't you just, do it in my garage? Yeah, because it's not a safe environment. That's why it needs to be the level it needs to be. Because as you just pointed out, how surgically invasive is this?
Yeah, very, very.
And in your mind, can this be done in a nail salon?
No,
Right,
not
okay,
at all.
that's what I thought. So yeah, that's why we built All Day House, and it's big. So Seth, if you can play the video and share it with everyone, that would be absolutely wonderful. And we're back. So there it is for anybody who isn't going to turn up. Now, some optimistic news. We are not allowed to use the premises for clinical activity until the CQC has come in and ticked that what you've just seen is all right and safe. Is it Tuesday? Next Tuesday?
I'm not 100% sure.
Does anybody know? Because I heard somewhere, somebody told me that the CQC might be turning up next Tuesday. So don't quote me. I'm pretty sure I didn't imagine I heard it. I'm pretty sure somebody called me yesterday morning and said the CQC are turning up next Tuesday. If they turn up next Tuesday, and if we tick all their boxes, hopefully the following week, Monday onwards, maybe, possibly, we'll all be in there now, having surgical revisions. It's huge, so there's, plenty of room and everyone can chill out. Anyway, back to the medical safety point.
Mm-hmm.
You've been reviewing patients and we're documenting some data on this, aren't we?
Yes.
What are you looking for in the data?
Well, I mean, to start with, we're looking for medications. We're looking for what patients are on, how common they're on. certain medications, often blood pressure, often, you know, diabetes medications, things like that. And we're seeing kind of if there's links, patterns, and soon we're going to be hopefully bringing in some blood testing as well.
Can't wait for that one.
And-
Bet you're all dead excited. Yeah.
And at that point, we can also check to see actual numbers to see people's health improvement.
As opposed to, oh, I'm all right.
I feel okay. I feel okay. Good anecdotal story.
That great medical diagnosis. Yeah, I feel fine. Yeah. Yeah, we can't go off that.
And so hopefully
Yeah.
we can take, you know, we can have some blood testing before any kind of procedure happens and after and see differences in front of us. And that's the main goal.
I just know this from 27 years. The patients who've only ever had problems beyond year one with their implants is when the health has gone south. Because the general health seems to do something with osseointegration if people don't take care of it. And I would ask over and over and over and over again and go, yeah, can you give me your last blood test results? Oh, I haven't had one done for 4 years. 4 years?
I know.
Just for my own sanity, remind me again, is it normal practice for blood screening in other countries every year?
Yes.
Once you go over 50, definitely.
Yeah.
So why aren't we doing it again? Tell us.
It's not in money. It's not in the guidelines.
That's what I thought. It's not in the guidelines.
It's not in the guidelines.
Although
right?
it's the easiest thing to read, to see how well someone is actually doing at a health level. Yeah.
Yeah.
Right. Not in the guidelines. The easiest thing to do to know that someone's okay. I wonder who wrote the guidelines. Do we know who writes the guidelines, or is it like some secret society?
Well, I mean, they're senior health officials.
I see. Okay. So they're real mortals.
They are.
People.
Yeah, they are people.
Right. Okay. I don't have to telepathically communicate with them or anything.
No.
Right.
No.
Okay. Okay. So yeah, but just from what you're seeing on the list of medications and HbA1c readings and this, that, and the other.
Well, I mean, I'm sorry to interrupt on your train of thought there, but we have, you know, we do have patients whose body rejects the implants, you know, 4 years later.
Sorry, did you say the body rejects the implants, not the implants reject the body?
Well, yeah.
Right, okay. That's because the body is the living thing and the implant is just this dead titanium screw.
Exactly.
Right, okay. Yeah.
And on kind of deeper dives, we've realised that, well, actually, they stopped looking after themselves and their diabetes, blood sugar control, don't need to say anymore. It said exactly what it said. So, yeah, their diabetes control got a lot worse. And, you know, 4 years later, you saw that the body did not respond well to that and didn't respond well to the implants. And the implants became loose.
I know this because I've quoted this before. My own mum, who's now, 41 years with implant functionality. Yeah, she's a frail little old Asian woman. Double hip replacement. Diabetic, but well controlled. A bit of blood pressure. 85. Implant's still there. But she knows full well, and she remembers crystal clear, her implant surgeon saying, well, if you want them to last a lifetime, you better take care of your health. Yeah, that's exactly what she does, and that's why they're all still there, and that's why she's happily chomping away with her gnashes. And she keeps reminding me every single year, because she's got a master's in economics, which only ever comes out to quantify how much money my dad spent in the 80s having her rebuilt, and every year she tells me how much better value my dad's got for the money he spent. As every year goes by, it's a wonderful conversation. It's really, which is good. It's good. She doesn't know how much her electricity bill is because I pay that, but she definitely knows the value in her
she's
implant.
getting.
Yeah, exactly.
Yeah, of course.
Yeah, she doesn't care what the electricity bill is because she knows I pay it. If
Yeah.
you know what I mean, yeah.
But you can see the value for money when you see people on the Facebook group or asking other people their ages and whether they'll last, and I think the overall consensus is if you look after yourself, the implants will last.
Yes. But isn't that the same for all medical devices?
Pretty much.
Pretty much. Right. So it's the same rules. But for some reason, and I know this is a weird narrative, right? For some reason, this bit is just not this bit.
I mean, yes, it should be, because it's one whole body.
That one. Yes. Yes.
But it's not described that way in any of our kind of teachings at all, in medical school or after in GP training. And
Yeah, but
I know
medical school and dental school are like joined buildings. We're like in the same building, and for the first 2 years, we interact a lot with each other, and suddenly we go that way.
bye-bye.
Weird.
It is.
Very odd, yeah. And actually, in our triage pathway, I don't even care what's going on in the mouth until I know it's medically safe for them to have an operation. Sorry, Christine sat there quietly in the background. She's saying nothing. Is that true, Christine?
It is true.
Yes. So, yeah, all kinds can be going on in the mouth. And yeah, we could probably fix all of this. But if your medical health is screaming at me saying there's a high risk that bad things are going to happen to this person if we operate on them, it's a no. And I know people hate the old, oh God, they gave me a no. Well, you have to understand that one of the reasons, particularly on medical grounds, is to take zero risks with your life. Zero. It's a red line here and it won't be crossed ever. Am I right?
100%. And, I do have to be the bad guy often and say, look, we can't do it. But at the end of the day, it is a risk. It is a line I won't cross. It's a risk that I won't take, because at the end of the day, I want to help as many people as possible. And
But
I'm not going to risk their life by doing it. It's just
Yes.
not worth it.
nope. I understand the desperation. I understand what it took to make the phone call. I understand what it meant to reach out. But if you're truly invested in yourself, and our clinicians, our GP says, improve your HbA1c readings, do it. Because it's better for you.
And I say that to people, even when I speak to them about anything, at the end of the day, improving, your diabetes control or something just helps you improve your own life and improve your own body and your own health. Because at the end of the day, you can buy certain things and whatever, but you've only got one body, and looking
Yeah.
after yourself is very important. You can't just replace the whole body. You can replace parts, obviously, but you can't replace your whole body.
The reason, if you remember, when I interviewed, when you and I spoke for the first time, even you were a little bit, what are you asking me to work here for? Kind of thing. But now you're here. Now you've been here for quite some time.
Mm-hmm.
How important is medical profiling of patients? Our patients, the ones who need us.
Oh, incredibly, because so many patients are on so many medications. I mean, people ask, when I say I work here, I work at 21D, they always ask me, they say, oh, so what do you do? What's it about? Because it's not something that they've seen. When we first spoke.
What? Doctors and dentists working together.
Yeah, essentially.
Do you have any idea how weird that sounds?
Yeah, of course.
Right, okay.
And so when I explain it and when I get to the crux of it, essentially, it's about keeping people safe. It's about improving their health and keeping them safe. And that is, as GPs, what we all really want to do. And this actually helps so many people improve their own health.
I read the stories on the group.
Mm-hmm.
You do. We all read the stories on the group. How many of them, in a matter of weeks, report huge improvements in their energy levels, their general health, the well-being, just the entire landscape of their life has changed. They're so much more energetic, so much more want to do stuff. The confidence has come rushing back, but the confidence without the actual energy of the body isn't going to go anywhere. And you know this as a medical professional, when we remove huge amounts of underlying chronic festering disease, let's call it gum disease, let's give it a name. When we remove that, how much burden have we taken off the body, and how much energy was it spending before fighting that crap?
So much. I mean, your body uses so much energy to fight infections, and your body can feel it. When people say, you know, they're feeling tired, they're feeling run down, they're getting headaches, all can be linked to any kind of chronic inflammation, any kind of chronic infection. And you know what? I'll say it, in my day job, well before I knew about 21D, I didn't think to look in someone's mouth to see where
What
this
you mean,
chronic
what they were
infection,
speaking out of and what they eat through.
Exactly.
Right. Okay.
And so I personally never thought about it. And it's just opened my eyes, and you can just see the burden of disease.
That's right there.
Yeah,
Right there.
exactly.
But you don't even, they're talking to you, you can see it right there. Right, okay.
And you can see that it's gone once they've had kind of full mouth rehab. So quickly, like how there aren't many procedures that work that quickly, fix so much so quickly.
Isn't it staggering?
Oh, yeah. From
It's the one thing I look for, right? It's the one thing I've always looked at. I would see them when I was a practicing clinician, very long time ago. I would see them at sign-off. And of course, I would remember the day they came in. And the word I used to use was, "You look bright." And they'd go, "Hmm?" It's like, "You're glowing. You're just the best you I've ever seen in front of me right now."
What part is it though? Because medically aside, if you think about their confidence, they're psychologically so much better in themselves. They smile.
A lot.
A lot.
A lot.
And it's something we hear all the time. I read on the Facebook group all the time about people are suddenly smiling. And smiling will help you feel better in yourself.
But that's even documented in medicine. Happy people function better. It's just a fact.
100%. That is the truth. But even if you just smile more, your whole mental health does improve. Now, I'm not saying, stand in front of a mirror and go,
Why not?
Well, it needs to be a bit more of a laugh, a bit more of a smile. But having a true smile does, documented, improve your mental health.
Since you've been hanging out with Ed, our healthcare economist, and you two have been trawling through the clinical papers, tell me how worrying is some of the shit you're reading in there?
I mean, let's think about some of those clinical papers and some of the things that that I researched, that Ed is now also researching when it comes to...
And we are now publishing. Let's see how many people read it.
Well, I hope a lot.
I hope so too, because it's pretty important stuff. Go on.
But so some of the papers that we've found rather than publish was linking kind of gum disease and oral health with let's go Alzheimer's to start with.
Thank you.
And linking.
But you know what the worst part is, Nitesh? Sorry. The first papers on this came out 20 years ago. It's not like yesterday's paper. The first papers on this, I read them 20 years ago, 2 decades.
And they did. And the papers that I was reading was showing that some of the bacteria that's found in the mouth, guess where it ended up? ended up in the brain.
Yeah. Paramonas gingivalis. Yes, I am familiar.
That's the one.
Yes.
Found more commonly in the
The
brain.
blood-brain barrier, one of the hardest barriers to cross. This thing managed to get there. It only originates here. It does not originate anywhere else.
And it's found in the brain of people with Alzheimer's.
I mean, if we look at the diseases that are affecting people now into their old age, and then you suddenly start reading the clinical papers that is linking advanced periodontal disease to these diseases. What is that rubbish that they're going about? Causation or, effect? All I know is this. You have rampant chronic disease in a part of your body, and I'm staring at it. And I need it to be gone, because there's no harm in it being gone, but there's plenty of harm in it staying there.
Yeah,
Right, okay. Of course. That binary.
of course.
And medically, when you look at, I was reading somebody the other day said, and it's not the first time I've read it so many times. IBS. Now you work here. How many people do you think you've been prescribing symptomatic relief for IBS when the problem was they couldn't actually chew their food?
So many. Because, you think about it. If you can't chew the food, you're then buying softer food. Now, this softer food has been made to be soft. It's ultra processed.
Yep.
And it causes inflammation in your body.
Yep.
It causes your gut to scream, essentially.
Yep.
And that is some of the IBS symptoms, is your gut screaming. Your gut is struggling to process some of the foods. And that's because people are struggling to chew. Say an apple. I see an apple quite a lot when I look on the Facebook group and things. And, you see people eating, the crunch of an apple, a solid food. The body doesn't scream when you eat an apple. Whereas if you're eating an ultra-processed, soft, I can't even think, bread, ultra-processed bread, your body doesn't like it. It's not natural to eat ultra-processed foods. And so your body doesn't like it. And we treat that by giving tablets to help. And sometimes, we can talk about different diets and different ways that people can help themselves as well. And there are different diets that we can give, kind of almost complete elimination diets, to have pure basic foods and slowly introduce foods to find out what your body's screaming. But you need to be able to chew them.
Yeah. That's why we got them in the first place. That's what they're for. Can you think of another body part where if you just lost it or it just became a bit wobbly one day and fell off, where a medical professional wouldn't freak out about that? Let's just say your ear got a bit wobbly and it just fell off. And you went to the doctor with the ear in your hand. Do you think he'd have a Barney? Or do you think he'd go, it happens, don't worry about it. You've still got the other one, it's fine, bugger off.
I think they'd be slightly worried. And you said ear, I was thinking toe.
Okay then, the toe. It just went wobbly. Yeah. It's been wobbly for a few weeks and it just fell off. Or my foot just fell off. I've hopped here.
I was going to say, please don't walk into a GP practice with it in your hand.
Do you see any difference between that body part, this body part, and this body part as a medical person?
An infection in any part of the body
Yes.
is the same.
Yes.
An infection in any part of the body still causes a significant problem for you.
Yeah.
Obviously, if you have an infection in your finger here compared to an infection in your heart, it's different. But an infection still causes a burden on your body. And if you've got a chronic infection, that burden is just constantly there.
And how energy draining is it for the rest of the body to deal with a permanent, chronic, long-standing infection?
Almost think, okay, if you have chronic diarrhea, your stomach's always hurting, but also it's not just that's hurting. If someone has, we've all been ill, that for a short period of time, but permanently, that is kind of a disease of your gut, and that's struggling, and your body struggles. You struggle mentally, physically, emotionally.
Everything.
It's the same in the mouth. It is.
Yeah, and yet it's not spoken about that way, is it?
No, not at all.
Why? Who decided that?
That's a question I don't
I
think
just,
I can
I just
answer,
keep
to be
coming back
honest.
to that question. I just want to have been. I want to build a time machine and go back to that committee meeting and go, what are you all talking about? Because it's the mountain of disease we deal with. We haven't built All Day House just because we want a big empty building. We've built it because we're looking at the demand that is coming our way for people who definitely need what we do.
I mean, at the end of the day, if they don't need it, we don't do it. So,
Do we need to go looking for work in this place, Christine, or are they just coming anyway?
They're just coming anyway.
They're just coming anyway. That's what I thought, right? So we definitely don't have people walking around with sandwich boards going,
No.
get in here.
No Santa Claus.
So, they're there, and the stats don't lie. The government produces data. Adult Dental Health Survey says over 2 million people have no teeth. If you read a medical paper in a medical journal or something from the ONS that said 2 million people have no hands, you know what that sounds like to me? Sounds like a national crisis to me. That's what it sounds like. They have no teeth. Well, if we didn't need them, and if a set of plastic castanets did its job, I know that that's what we had back in the 1930s, and nobody jumped down my neck, oh, it's all I can afford. I'm not debating on economics. I'm debating purely on the basis of clinical need for correct function.
yes.
On that basis, how is it acceptable to have 2 million people with no teeth in a civilized country
It isn't.
with a healthcare system?
Well, of course,
Apparently.
it isn't. Of course, it isn't. It isn't acceptable at all.
Most of them didn't spontaneously get there. There was a journey to get there. It was one by one by one by one. And then how many do you have to go along before you go, wait a minute, we know where this is going to end up. Maybe we should stop it right now. Yeah, that kind of stuff. And it's a degenerative disease. It's a condition that affects people from our data, primarily over the age of 50. And it's like a hip replacement. How many people do you do a hip replacement on who are 25 compared to how many you do them on who are over 50?
Well, exactly. Obviously,
Right, okay.
the vast majority are older, aren't they?
And the reason we're seeing these diseases more and more, and you will definitely be seeing it more and more in your GP practice, how many more conditions of later age are you seeing that at a scale and at a volume like we've never, ever seen before?
Yeah, of course. And as someone gets older, they tend to have more health problems, and we are seeing that more and more and more. And heart disease, say, we are seeing that in ever increasing quantities. Whether people have had heart attacks or their heart just doesn't pump like it did, when they were 30, and you can see that more. And I mean, I know I'm going back to kind of some of the papers and things, but your gum disease.
Well, that's where the answers are.
Well, your gum disease can make kind of your heart and heart problems a hell of a lot worse.
Are you saying that there is a connection between gum disease and heart disease?
Yes.
Anyone from the British Health Foundation that is watching this, please take note. Continue.
I mean, there is a page on the British Heart Foundation website.
On it,
Yeah,
correct. We've got
talking.
about 30 clinical papers on the subject as well.
And it's, you see when people are having certain, heart operations or something, that they do have to check what's going on
Yeah.
in the mouth because of the
Yeah.
infection and where it can travel.
Yeah.
And if someone has an infection in the heart, one of the places...
Have you noticed they never ask anyone to have their fingers or toes checked? Just the gob. Have you noticed that?
Yeah,
I wonder
well,
where
mean,
all the horrible bugs live. Any clues from that? They do just say go check the mouth, right? They don't go check your fingers and your
Yeah,
toes. And
yeah.
just the gob.
Mm.
Right. Okay. That's what I thought. And yet, still, we're not taking this seriously enough. Sorry, as you've noticed, I'm in a bit of an arsey mood today because this has been a bugbear of mine for 27 years. Because I get really infuriated that somehow I'm doing a cosmetic procedure. No. It has a cosmetic outcome. But the number one reason I'm doing it is to try and prevent very horrible things from happening later on, as soon as I get my hands on you, basically. So, yeah, that's why I'm getting a bit arsey about it, because it's like a circular conversation. I've had this conversation 27 years about the importance of medical health to this, how this procedure improves your medical health, but equally there is a duty of care on your part to maintain that improvement. Don't piss it away again, for want of a better term.
This should be seen. This should be seen as an investment in your own health. But that means that you have to keep investing in yourself.
Yes.
Invest in yourself. I'm not talking about kind of for the implants. I'm talking about, foods, lifestyle, drink a little less, eat a bit better, stop smoking, all the lifestyle factors that are important in just improving your health.
Because oral rehabilitation is not really spoken about, and the importance of controlling and eliminating gum disease isn't like up there somewhere, it's almost become like, oh, I've got some loose teeth, or I've got a load of teeth missing and I'm just embarrassed. No, you can be embarrassed, but trust me, if there's active disease, you're also sick. Mm-hmm. You understand? We're not talking about that enough. You may be embarrassed, I understand that, but there's also infection that is entering your bloodstream and going everywhere.
And speaking of going everywhere, I was speaking to one of my colleagues about people with hip replacements and titanium hip implants, and if they get an infection around that implant, one of the places they look to have a look in the gob.
It's funny how they always look when it's too late.
I knew that was coming.
Yeah, but come on. This is not spontaneous. It doesn't just happen.
No.
There's numerous touch points where somebody could have gone, open your gob, let's have a look. Let's take a CT scan. Let's measure how much disease is in there. It's not rocket science. It's not difficult. And it doesn't cost that much. But it will save a lot of grief, angst, money for a lot of people if we just did earlier screening. I know someone watching this is going to jump down my throat.
If we took, say, money aside, that person who's had the hip replacement has then had to go into hospital for some antibiotics to put through a drip, for some fluids, and that could be a really preventable issue if someone had, sorted out gum disease beforehand.
I've asked you this before, but I'm going to ask you again to refresh all the new people on this group. Since you started working here as a GP, now, today, out there, when you go and do your stuff,
Yes.
are you obsessing about their gob, not just what's coming out of it, but also what's in it now?
Yes. Of course.
You say, of course. You make it sound like all your mates are doing this. I know all your mates aren't doing this.
Well, no, I wasn't doing it.
I know you weren't doing it. You told me you weren't doing it.
And I think I said it earlier today as well.
Yeah.
Because it's just, again, not something I've thought about. And now it's something I talk to people about when they come and they speak to me about being tired, or when they speak to me about different things. Well, just open your mouth for me. Let me just check. Because
I bet you're known as the weird GP in your practice, aren't you? He asked me to open his mouth.
I mean, that was before I even started working here, but that's different.
Right.
But yeah, no, yeah, exactly. He's like, why? Well, gum disease is still there. Still
Let's talk
exists.
about some of the magical drugs
Mm.
that people turn up here with. My personal favourite. Let's talk about sertraline.
Ah,
Yeah, so off you go. Let's talk about sertraline, my personal favourite.
well,
Tell us why you lot dish it out, and tell us what differences are in the doses, please.
so all antidepressants. I mean, one of the
There's
biggest,
an antidepressant drug.
one of the biggest kind of range is something called SSRIs,
Yeah.
of which sertraline is one of them.
Yeah. Give us the names of the others, seeing as we're on a roll.
Paroxetine, vortioxetine, fluoxetine, citalopram, escitalopram, and I'll stop. But there's so many, and sertraline's probably the most common one.
Yeah.
Probably just because it's in the forefront of GPs' minds more
Yeah.
than anything.
Yeah.
And people come to us in my day job as a GP, low in mood or anxiety, and we talk to them, different ways, kind of coping mechanisms, things like that, therapy, different options, talking therapies, kind of thing. But sometimes
It's the pill.
sertraline is the way forward, and what they want as well, and what people want. And I kind of understand that. But sertraline, and as all SSRIs, as doses get higher,
Yep.
they put bigger risks to implants, and the body is more likely to reject implants
Right.
if they're on sertraline, and particularly higher doses.
So when we get those that come in and they're 150 milligrams sertraline a day. I don't know about you, but I've got these hairs on the back of my neck that stand up. What about yours?
It certainly makes me look twice. It certainly makes me look twice
Right.
because, I mean, obviously it's there.
They're on it for a reason.
It can, yeah,
Obvs,
exactly.
obvs, I get that.
They're on it for a reason, and it plays a very important part. But often people get put on it, and the doses just go up, and no one reviews it once they're on it.
So at least it's worth a conversation to try and bring it back down to 50 and under.
It's
That'd be
it's
okay with you?
100% worth a conversation, isn't it?
So when we say we want that sertraline number to be 50 or under, ideally not on it at all, but if you must be, fine, 50 or under, we're not trying to wind you up.
Nothing we do when we give advice, whether it be kind of about, the physical health, dental, in any way, our advice is not to wind people up. I know it must wind people up.
Yeah.
But our advice isn't to do that. Our advice is there to help. Like we are all we are trying to do is help, whether it be kind of physical health like diabetes, whether it be mental health like depression. If there are ways we can help, without without operating or without in any way we can help, that's what we're here for. That's
Yeah.
what we try to do.
Pick another drug of choice that winds us up. There's quite a few. Pick one.
Is there any? I can see there's some in the front of your
Okay,
mind right now.
blood thinners. Let's talk about warfarins.
Okay. So warfarin, again. So warfarin's there to thin the blood.
Yes.
It's there to, and it's generally used less and less now.
Yes.
Which
Good.
which is
Good.
very, very good, because I mean, for nothing else, it's pain for patients because they have to get blood tests
Yep.
every few days, every week, whatever.
Carry
to keep
around a
it
little
going.
yellow book.
Exactly. And people these days who are on warfarin are often on warfarin because the newer medications that thin the blood, there's not been research on them, so they're not on the newer medications. But also it might be because they've got something like a mechanical heart valve.
Yeah.
Now, if someone has a mechanical heart valve, it is not safe for us to ask
Yeah.
you to lower your INR, to lower the amount you bleed, and to make your blood sticky again. because that can cause clots. Clots, whether it be clots in your heart, clots in your brain, give you a stroke,
Yeah.
heart attack. It's just not safe. And warfarin, we do need to be very careful with people. And I mean, I don't need to tell you, but the surgery itself, it's a very vascular area, isn't it? And
Yeah.
obviously it can bleed, and we do everything
does.
we can do everything we can
Yeah.
to try and help
And it'll just
reduce
start
the
again.
amount of bleeding.
Yeah, and it almost always just starts again.
Exactly.
Yeah, and then
exactly.
they all panic and go, "Oh, I'm bleeding to death." No, it'll take about 3 weeks. There's no chance you're bleeding to death. But patient in a panic, and that just raises the blood pressure.
Of course.
More.
Of course.
more.
And so when someone is on a medication like warfarin, I have to look very carefully at why and what's going on. And so I
Yeah.
may ask, I may be a bit more nosy and be asking, why are you on warfarin?
You're not being
What's
nosy,
going
because
on?
that's what medical professionals are supposed to do.
But-
we need the answers.
That's exactly what I was about to say. We need,
Yeah.
we need to know to make sure what we do is safe.
What about the clopidogrels and the apixabans of this world?
So apixaban is a bit more like warfarin, and generally it's safe to stop 2 days before, restart, to a day later. Normally is what is perfectly fine. It depends again what people are on that for. Generally, it's because their heart isn't beating quite in the normal rhythm, and then that's completely fine. Some people have had a recent blood clot, whether it be in their lungs or their legs or somewhere, and they're on kind of apixaban or similar, and that at that point it's not safe for us to stop, because the most common thing that's going to happen is if we stop it too soon, your body has another blood clot.
Yeah.
And once you've had a stroke or a heart attack, your risk of having another one soon after, if you're not on the right treatments, is very high.
Yeah.
And so
So generally, we won't operate on patients who've had a stroke or a heart attack for a year.
exactly,
Right.
because
It's another
the
thing
risk-
people get annoyed at. Well, why not?
But it's all safety. My whole thing, my whole ethos is safety, and this is all about safety. Now, moving and thinking about aspirin or clopidogrel, which is what we call an antiplatelet, and that makes the blood less sticky. And I have to make a decision based off why someone is taking those medications as to whether they should stop it or continue it throughout our procedure.
Yeah.
Obviously, if they continue it,
gonna bleed more.
They will bleed more.
Yeah, but you know this. You know the anatomy of the area. Unless I hit the lingual artery, which chances are 0, who's going to bleed out through the mouth? And how many years will it take? And do you think someone might notice?
Exactly. So
Your
I think
cornflakes has turned
so-
red, Leonard. That kind of stuff.
So I think
Go on.
no. So
I'm sorry, I'm in a daft mood because this is the kind of nonsense I listen to. Okay, it's like I don't know the area I work in. All right, okay, go on.
But I mean, what it would mean is that the bleeding will take longer to settle down.
But it'll settle down.
But it will settle down.
Right.
And some of the things that we talk about is ice packs, ice cream.
Ice cream. Yeah, I don't like ice cream. I don't give a shit. Eat the friggin' ice cream. Just eat the damn
It's the
ice
cold.
cream.
It's
the
it
cold.
It constricts the blood vessels, stops the blood from getting to that area as much. It's like people's fingers go cold, in cold weather. It's because the body's trying to keep all the heat in.
I would love to be able to cryo-freeze them all for 24 hours, but apparently that's illegal.
Did you ask?
No, but I have a feeling that is totally and utterly illegal. But go on. I digress.
So
I can guarantee there will be no bleeding at the end of those 24 hours, and no one will let me try. Anyway, go
But
on.
what I did want to say is, even if they continue these medications and their bleeding would be a little bit higher,
Let's
I'll certainly-
contextualize the bleeding, man. What bleeding are we bleeding talking about here? Are we talking pints or are we talking thimbles? Seriously.
We're talking thimbles, and
Right.
The other part is obviously that your body is producing saliva. We are
Yeah.
we're doing things
And it's
in an
clear,
area.
which means you can't see that bit. You can only see the red bit.
But if you think, okay, if you have some kind of blackcurrant squash of any kind,
I'm so glad you went down the Ribena route because I was going to go down there myself. Go on.
well, you put in, you could
Just a
literally
little.
put in a drop or two, and
Yeah.
you can see the colour of a full normal glass
Yeah.
change.
Yeah.
And you put in a couple extra drops, and you see that change,
Mm-hmm.
and it gets dark very quickly.
Mm.
And so it's not just blood that most people are seeing, that the vast majority of people are seeing.
Mm.
It's mixed in with the saliva.
Yes.
And that looks, obviously, it looks scary. I completely get it. We're not, people don't
Yeah, but
generally
when the
see
medical
blood.
professionals say, don't worry about it, it's not a two-way conversation. Just don't worry about it. Well, if they're not panicking, why am I panicking?
Exactly.
That kind of stuff.
Yeah. If we're not panicking, you shouldn't be either, really.
The problem that I have is, have a panic. It's just the scale of the panic. Have a little panic. Little panics are okay. Big panics raise blood pressure horrifically, correct?
Well, yeah, and I mean, if your blood pressure's going up, you're going to bleed more.
That one. Yeah, so it's all linked. So panic more, bleed more. Panic more, bleed more. Just vicious cycle. Just keeps going round and round.
I think the best thing we can possibly say post surgery is chill and
Yep.
eat ice cream.
As I've always said.
It's my keep calm and carry on.
Yeah, exactly. As I've always chill and eat ice cream. Haagen-Dazs should be thanking me for prescribing it as a medication. They don't mention this in any of their advertising at all. They're missing a trick here. Every full mouth implant patient in the world should be prescribed Haagen-Dazs, not Ben and Jerry's because they've got rough bits in it, right? It's Haagen-Dazs, very
Smooth.
specifically
You
smooth.
want it smooth.
Smooth and cold. Lots of it.
Smooth and velvet-like, really, isn't it? That's
Haagen-Dazs
what you
should
want.
start a pharmaceutical division off the back of what I just said. I'm telling you now. With a big plus on the side of it. This medical grade Haagen-Dazs. Medical grade vanilla. Yeah. They should
Suddenly,
do it.
the price will shoot up.
Exactly. It would triple. The price would triple overnight. See, if you're watching, if any of you from Haagen-Dazs are watching, you can have that one. It's free. It's all right. It's all right. You can have it. And the other one is the antibiotics thing and getting the thrush thing. Correct me if I'm wrong, but thrush generally is because you're run down, right?
Yes. Yeah.
Right. Okay. So
What-
we give you antibiotics, and people think it's the antibiotics that does it. No, it's the fact you're run down, and your body's just not very good at fighting it.
I would probably say it's a little bit of both. But we give the,
Come
the
on,
emo-
they're run down.
Well, they're 100% run down. But
Right.
what I'm saying is like in a normal day job, if someone has a chest infection as a GP, I would prescribe amoxicillin.
Yeah.
It's very rare that people would then get oral thrush from the amoxicillin I give them.
But that's because they've not had their mouth rearranged by us.
That's where we were going. That's where I was going. It's because
Because we've just had a cold, nothing else.
What we have done here is we've messed the whole bacteria area, and
I think you'll find the word you're looking for is improved.
we
Right. Okay. this
we've
mess
improved.
Thing, I'm
But
sorry.
there's
Need to be a
there's
bit clearer.
there's
Okay.
what's going on there is different to what your body is used to. Now,
What you mean healthier? Yeah. All right.
yeah,
go on.
okay, it's a lot healthier than what your body is used to. But what we need to think about is if it happens, often it's quite mild and they don't need any particular kind of treatment. Swirling with kind of salt water and things does the basics for most people. Now, I know some people have struggled to kind of get nystatin, which is one of the medications, but that's prescribed. That is a prescribed medication that they need to see a pharmacist or a GP about.
Yeah.
But there is an oral gel that you can have, that you can just buy, without needing to, you know, speak to your GP or pharmacist. You can go into any
Are you
kind
going
of
to give us a
pharmacy
name, or am
and
I
buy
going to
it.
wait longer?
You were going to wait a little bit longer because I saw the eyebrows raised, and I just wanted
I'm
to
just
see
waiting
them.
for the
Yeah, I
punchline
know.
here.
I
How
was
long's this
waiting
going on for?
a
All right,
little
go
bit
on.
longer.
Yep.
So it's a myconazole gel,
Myconazole gel. Myconazole gel. You can buy it over the counter.
and you can just buy it over the counter without the need for a GP
There you
or
go.
pharmacist.
There you go.
I was just keeping you on your toes.
Yeah, I
a
know
little
you
bit.
were. You were really, it was really getting to me. I thought, when's he going to bloody tell us?
I was watching the eyebrows get higher and higher.
But we have to have them on antibiotics. We just have to have you on antibiotics.
And
You
the
have
antibiotics we choose
Yeah.
are the best ones for what we are doing in order to stop you getting horrible infections afterwards.
The mouth is a particularly sensitive area because we can't just tape it up like you lot can with everything else you do.
Yeah, of
Because
course.
you've got to eat through there.
You
So
change.
yeah.
You have a hip replacement. It's all tidied up afterwards.
Tidied up, closed up, can't get anywhere near it at all. But here, we have to trust you, and you have to eat and drink and introduce all stuff that has never seen a gamma sterilizing unit ever before into a freshly operated on site. Otherwise, you're not going to heal. So it's a combination of all of these things. So we can't really mess about. And I know some of you get thrush, but it's going to happen. But it's
Yes.
like, it's all got to do, in my view anyway, I've noticed this, they're run down. And it's almost like the anticlimax that Christine spoke about before, the adrenaline crash and the rundown and the, oh, have I done the right thing? Oh, feeling sorry for myself at day 4, 5, 6, 7. This is all part and parcel of this journey. It doesn't happen to everybody. It happens to some people. But I'd go so far as to say, don't freak out about it. It's part of the process.
Yeah.
If it happens, probably won't.
But if you think about kind of the surgery that we do,
Yeah.
okay, if you go into hospital to have your gallbladder taken out, let's
Yeah.
say, right, you expect to feel rubbish for a good few weeks afterwards. But you should expect to feel just as rubbish after this. This is still, you know, a significant surgery. The body needs time to heal.
I was in Turkey last week. Bit of a segue, but I'll tell you the story. Minding my own business, and at the next table were people who had come to Turkey to do pretty much what I do, but not how I do it. So one chap was happily telling another chap how he's had his teeth out today, and they've told him he's not going to have any dentures for 6 months, and then they'll see whether he's got enough bone left to have implants put in. And the other fellow went, "Oh, that's rubbish." The other fellow went, "Oh, that's rubbish. I've had all my teeth out today. I've had 8 implants in, and 8 implants just in his lower jaw. Where they found the room, I have no idea. They've put him some dentures." And he went, "Oh, really?" And then the guy who'd had the 8 implants turned around to the other fellow and he said, "Yeah, I can't put them in because every time I put them in, I feel like I want to rip my head off." And I was thinking about that, and I was thinking, you know what, if that's all I had to do, which is just take some teeth out and then go, right, bugger off for 6 months, and then put some screws in and make them a denture and go, if you try and put that in, your head will probably explode, and then spend the next 6 to 12 months building it bit by bit. This would be a walk in the park. But who's going to tolerate walking around with no teeth for 6 months? Please put your hands up. Right, no one. Right, okay. That's why we do it the way we do it. And it is actually more predictable and far more controlled this way than any other way. And that's why we do it this way. But there are no shortcuts. 3 hours to go from one point to another, which is what we do, as far as I'm aware, is the most streamlined system ever of covering a fresh surgical wound with a rigid, titanium reinforced prosthetic immediately after surgery. There are so many procedures where they put nothing over that site. Could you imagine that?
No.
Right. Okay.
No, I can't.
For me, I just am in my own head. And these two chappies who was out there just talking about it like, oh, just gone and had some screws put in. Can't eat anything. We're in the buffet now. Can't eat anything. They've just got, like drinks, and everybody else is eating, and they're just staring at everybody and just having this general chat. If that was my job, A, it would be a lot cheaper, and B, it would be a lot simpler. But I have this feeling that absolutely no one who comes to see us would spend 10 minutes with no teeth. Am I correct, Christine?
Of course not.
Absolutely nobody. Right. Okay. So it isn't like for like. We've got a completely different approach here, and this approach, actually, I'm satisfied, my clinical team is satisfied, that it's the best way of going about it, the optimal balance of clinical compromises, and I keep stressing that word, compromise. If I'm having to correct you, you are just going to have to accept that you are in a compromised state, which is a prosthetic state, and I have to surgically intervene, put some screw foundations in, clean it all out, close it all up, and then screw some things on top that hopefully are going to function as close as I can possibly get to the teeth you once had. And the medical complications that go alongside this are that long?
Yeah. Yeah, of course.
You never thought this would be so full on, did you?
No. No. When my eyes were first opened, when I first saw
What we were shoveling out.
exactly
Yeah.
this, I had no
I remember
idea.
the words, holy shit. I remember them well. Yes, holy shit. Yeah, I thought, oh my God.
And that
this
was the
guy's
politest
been
thing
to
I can think
medical
about to
school.
say as well.
Yeah, this guy's been to medical schools, gone through GP training, and that was a freak out moment for him. There's millions like this, millions of people, and the thing is, it's a degenerative disease, and most of our patients are over the age of 50, which means they are not in optimum tip-top health of a 25-year-old. Don't you find that really weird? We only treat sick people. How much easier would this be if they were all 25-year-old triathletes with perfect blood profiles?
Yeah.
They just don't need the treatment, the gits. Have you noticed?
My job would be easier though.
Everybody's job would be... Healthcare professionals' job would be easier if everybody was just healthy and you went, yeah, you're fine. Bye.
Well done.
Yeah. But that's not what healthcare is designed for. It's designed for sick people, right?
Of course.
And you have to do horrible things to get them over to the other side. That's what I thought. So medication-wise, my gut instinct is we're probably going to become even more annoying on the drugs. What do you think?
I think we will too, because the more annoying we are, the safer we are.
So that's the takeaway message of today. We're going to become more annoying, so you're all kept a lot safer. Yes? And on that note, let's call it a day for this evening. Thank you all very much. Next week, I've decided that I'm going to talk about all my pet peeves, if any of you are interested. So tune in next week to hear what I'm going to come up with then. Thanks very much, and see you all next week.
Thank
Thanks,
you.
Nitesh.
Thank you.
Cheers. Thank you.
Cheers.
Bye.